Chapter 16, this is talking about diabetes and diabetes-related emergencies. So 90% of the people in the United States have type 2 diabetes, and it's caused by obesity, high-fat, low-fiber diets, and a sedentary lifestyle. Many of those people, that 90%, are unaware that they even have it or even are pre-diabetic. So it's a metabolic disorder, and it's characterized by hyperglycemia. And etiology, which means cause, is you have a reduction or absence of insulin production. And this is done by the beta cells of the pancreas, or you might have a defect of insulin receptors. One of those two things. So insulin is hugely important. It aids in the conversion of sugar and starches, and it to form a transported to cells and used for energy. There are three types: type 1, type 2, and gestational. So type 1 diabetes, it was formerly called juvenile diabetes, and also you were dependent upon the insulin. And type 2 was formerly non-dependent upon the insulin or adult onset. And then you have gestational, which would be during pregnancy. A fourth category has been started that's called pre-diabetic or impaired glucose tolerance. It's just impaired. You're not quite at the rate of diabetes, but you're knocking on the door. So type 1 diabetes is when you have an absolute lack of insulin. The pancreatic beta cells within the islets of Langerhans are destroyed due to an immune dysfunction. So you are dependent upon supplemental insulin for your very survival. Type 2 diabetes is the most common form seen in a dental office. This type of diabetes is on the rise due to the fact that we're living longer. People don't have as active of a lifestyle, and poor diet and exercise of adolescents. People used to tell their kids to go outside and play and come in at lunchtime, and then do the same in the afternoon, come in for mealtime. And after dinner, everyone went outside and played in everyone's yard, in the neighborhood, and you were to come in before dark. So people had a very active lifestyle. Nowadays, we don't do that, and therefore it is on the rise. So your body in type 2 diabetes is unable to produce enough insulin, or the body is not able to use the insulin that is produced. So it can be either one of those, but they do at least make insulin. So gestational diabetes is glucose intolerance with initial onset during pregnancy. Usually disappears after pregnancy, but it could return years later. And this is caused by an enzyme in placenta with destruction of insulin by the placenta. So if it's untreated, you can have harmful effects. It can have harmful effects on the fetus, such as hypoglycemia. So systemic complications due to diabetes, the major complications would be diabetic retinopathy, neuropathy, and nephropathy. So retinopathy is the retina of your eye. That's easy to remember because it is the leading cause of blindness. Diabetic neuropathy, neuro is nerve, so it's mild to severe form of nerve damage. It can affect 60 to 70% of diabetics. It's not real well understood, but you could get pain in the hands and feet and feel like it feels when your leg is gone to sleep and it's just coming back with circulation, and you feel those little pins and needles type of a feeling. This is what they can feel in the hands and feet. They can have really slow digestion, and other neurological problems are very common. So nephropathy, N-E-P-H, has to do with the kidneys. And so it's the inability of the kidneys to filter any of the impurities in order to clean the blood. And you have 100% morbidity within 10 years. Then a fourth is called macro and microvascular complications. You have microangiopathic changes. So remember that angio means blood vessels. So you have large and small changes in the blood vessels. So they can thicken and cause thrombi. You can have an increased risk of gangrene, which would culminate in leg amputation, and you can feel it in the hands and the feet. There's a tremendous lack of blood flow, which is causing the neuropathy. The change is found to be more severe in nerve capillaries. The fifth one is oral manifestations, which we're concerned, of course, about. If you have diabetes, you can have a delayed wound healing, and which can lead to secondary oral and systemic infections. You can have a better chance of having periodontal disease. So let me stop here and just talk about this for a minute. Diabetes does not cause periodontal disease, but it can affect periodontal disease because of the delayed wound healing and all of that goes along with diabetes. So you can have an increased incidence of it, even though it does not directly cause periodontal disease. You can have an increased incidence of abscesses, xerostomia, which is dry mouth, caries, so decay, lichen planus, and candidiasis. Candidiasis is a yeast infection, and it's a fungi, and it kind of looks like cottage cheese. And it can be on the inside of the cheeks, the buccal mucosa, across the tongue. It can be on the gum tissue, above and below the teeth, in your mouth. So the best prevention method is you need to maintain optimal glucose levels. And if you get a glucometer, such as this in this nice little travel case, it has everything that you need in here to be able to check your glucose levels on a daily basis and try to keep it within a certain range. So glucose monitor is used, what that is. It's a lancet or test strip inserted into a calibrated glucometer. The normal reading is somewhere between 50 to 150. So if you have less than 50, you have hypoglycemia, and greater than 150, you have hyperglycemia. So hypo is less than normal, glyce is sugar, and emia is in the blood. So it's less than normal sugar in the blood, or else you have greater than normal sugar in the blood if it's over 150. There's an adjustment in medication that would be needed if it's really high or super low, or maybe just give a referral to an MD. And so this is a lot of times what some offices have these glucometers in the office and they test their patients. Most offices that I have worked with do not have these, and it's mainly a time issue. So you have an HbA1c test, and this is done by the doctor's office or the hospital where they take your blood. And what it does, it's a glycated hemoglobin test, and it reveals the patient's average blood glucose level over the past 3 months. So if you know you're going to get your blood glucose tested, then you can't just start eating correctly the week before you go. Get this and expect there to be a big difference, because as it says, this is going to be a average over the past 3 months. So they have home tests available, and the fasting glucose test that you can get. So the medications and treatments for diabetes on type 1 diabetics, they have to have some type of insulin, and usually they have to have it on a daily basis. There's different times based on the time of onset, when its peak effectiveness will be, the effective duration of how long it will last, to the minimum and the maximum duration. So it needs to be refrigerated to also lengthen the effectiveness. Then you have type 2 diabetes or diabetics. Their medication is based on the cause of it and the severity of the condition. So the more common medications that you're going to see from our patients in here, and I'm going to give both their names for the same medicine, you're going to, when you take health histories, you're going to be marking down a lot of people that are taking metformin. Well, if they're taking metformin, you know immediately that they have type 2. So it's also called glucophage, rosiglitazone or Avandia, tolbutamide or Oronase, glyburide or Micrase diabeta, I think you pronounce that, not sure, and glinase. So you're mainly, some of your patients are going to come by, I see them mark down this, Avandia, and I see them do this one, and a lot of metformin. But if they happen to put down glucophage, then you would know that it's metformin. So the most critical step for type 2 is the administration of 20 grams of some type of sugar if the patient is conscious. So it's a different thing if they're unconscious, because they can't chew and swallow if they're unconscious. So for the conscious patient, you want to give them like maybe a sugar cube, or we have juice boxes at the office in the refrigerator if your patient needs to have something really fast. If you get something from your emergency kit, they have different forms of sugar. They'll have a tube of 20 grams that you'll see a picture of in shortly, and they would need to eat the whole tube. So they need 20 grams of some type of sugar. So there's been recent advances for type 1. I mean, they've been around for a while. They're insulin pumps, and they replace the daily injections that get so annoying and painful for diabetics. So it's a compact device with insulin-filled syringe that is attached to a catheter, and this catheter is inserted just underneath the skin or subcutaneously, and the catheter would be then changed every 4 to 6 days, and in that way they have a better glycemic control. So this is a 12-year-old type 1 patient with an insulin pump, and you can see here that they insert that in, and it can last for 4 to 6 days, and that's much easier on the patient. Other recent advances for type 1 diabetics, They have transplants for the pancreatic islet of Langerhans cells, and that can help with this tremendously. So the concerns about that are that the need for continuous immunosuppression to prevent rejection, because once you have that anything foreign implanted in your tissue that's not, their body doesn't think is supposed to be there, it will immediately begin to produce cells that to attack it and get rid of it in your body. So these people a lot of times have to take immunosuppressive medications along with this. So they also have developed an inhalation device to deliver insulin. But the concerns about that is that you can have sensitivity using an inhalation route, and some insulin in the mouth and throat, it gets there too, so the sufficient amount is not always delivered. So if you're going to take something like from an inhaler, they're worried that it won't all go where it needs to go, but it will be dispersed around the mouth and the teeth, etc. So questions to ask all your diabetic patients. As soon as they say that they have diabetes, or you read it on their medical history form, you're going to be asking them probing questions. Do you monitor your glucose levels? If so, how often? What were your most recent glucose levels? Because they will be able to tell you a number. How are you feeling today? Did you take your medication? Did you eat today? So surprisingly, many will say no, that they did not take their medication, and nor did they eat before they came. So this is a huge concern, that sometime during your appointment, if they have stress to a dental office, they could be, you could be having an hypoglycemic reaction, and you just need to be thinking in your head, I hope that we have, juice or sugar. You need to know where it is, and if you have anything in case you need it. So you can also ask them, are you having problems with your eyes, your feet, your legs? Do you see your doctor regularly about this? Do you see an eye doctor yearly? Do you know your average hemoglobin value? The one thing that can deter the information flow a little bit is that if they don't have insurance, very often they are embarrassed to say that they know they have it, and they don't need you to tell them they need to see a doctor. They know that they need to see a doctor. However, they are, maybe they can't afford it. And so sometimes you'll go off as the dental professional, you'll kind of go off on this spiel about how they need to have this checked. And under their breath, they're thinking, I know that. Maybe I can't go because it's not that I don't care about my health. Maybe I'd rather put food on the table for my kids. Okay, so you need to be careful of how you are phrasing this. Anyone with diabetes knows that they should be keeping more control. So don't talk to them as if that's a new revelation. But you can say that, when you can go to your next doctor appointment, be sure, and maybe what you need is an increase in dosage or something, and talk to them about that. And that's a nicer way to put it, so that you just don't assume that they don't care about their health. So for diabetics, it's really great if you can schedule their appointment in the early to mid-morning. You want to keep their appointments short, so sometimes maybe they need to come back for another appointment so that you can finish things out. And I'm talking specifically about if they're there for a deep cleaning and you would like to do the upper right and lower right quads on a deep cleaning or SRP, you might make sure if it's a diabetic that you just do one quad and let them go and then come back for more. Instruct patients to continue normal dietary intake prior to their appointment. That can be huge. Check the patient's blood glucose level prior to any invasive procedure, or if the patient complains of not feeling well. And of course, you can only do that if your office supports the glucometer. So frequent recalls, examinations, and prophylaxis. So if you have someone who has diabetes, you might want to have them on a 3 or 4 month recall instead of a 6-month recall, so that we can keep all the bacteria and help at bay and try to help them prevent getting periodontitis. So topical fluoride is great when they leave the office, if that can always help. And recommending some kind of saliva substitute always helps, like in a mouth rinse, or they have gum saliva substitutes. Because xerostomia, as we may have talked about before, is that causes dry mouth. People that have a less amount of saliva in their mouth are more prone to decay. You need that saliva. It helps buffer the acids that you are ingesting. And so when you don't have a lot of saliva, the enamel is not getting buffered, and everything that you eat, especially of acidic nature, can really wreak havoc on with decay around the teeth. So what are the emergencies? The medical emergencies, for the diabetic is what they call diabetic ketoacidosis. So its acronym is DKA, and what that is severe hyperglycemia. They have more than normal sugar in the blood. And that's number 1. And then they have 2. The other emergency you get is hypo. They have less than normal sugar in the blood. So let's talk about diabetic ketoacidosis. This is not a real common occurrence in the dental office, but you would need to know this for possible board questions and tests. There's 5 types of patients at risk for diabetic ketoacidosis. The newly diagnosed type 1 diabetic, because they don't know all the ins and outs of their disease quite yet. Patients that are not medicating or eating properly, who just ignore the fact that they have this, and what they call brittle diabetics. Brittle diabetics are swings, really severe swings in blood glucose levels, and it can't, even though you're on medication, you'll swing really high one day, hyperglycemia, and then it will go really low the next day, and it just keeps going back and forth, and they call those brittle diabetics, and because it's very hard to control. Patients with infections are at risk for diabetic ketoacidosis, and those who overuse alcohol and or cocaine. So the cause of diabetic ketoacidosis is insufficient insulin levels in the blood. They don't have enough. So the glucose metabolism is insufficient energy source. So the body metabolizes fatty acids for the energy. So if they cannot get the energy from sugar because there's an insufficient insulin level in the blood, it's going to start metabolizing something else, and to try to get the energy for the body. So it will start metabolizing fatty acids. And if it does this too much, you can have a real emergency. So these, the signs and symptoms of someone that is going in or in diabetic ketoacidosis, they could have an alteration in their mental status, ranging from just drowsiness to full-blown coma. So usually they are dehydrated, they have poor skin turgor, and I can show you when we have our meetings exactly how you can check for that really easily on the back of your hand. The main symptom that screams it's diabetic ketoacidosis is when they have a fruity odor on their breath. So they have hypotension, less than normal blood pressure, and a fruity odor on their breath. Even if those are the only things, symptoms that are showing, you know that you've got someone in diabetic ketoacidosis. So the skin and mucous membranes can be really warm and dry. They could have an increased thirst because they are so dehydrated, and muscle weakness and severe fatigue. So how do we treat this? First of all, we need to determine their blood glucose level. And so you need to lower the blood sugar level with insulin, and should only be administered by a medical professional to prevent it from going too low. You contact EMS, of course, immediately. What this person needs to fix them are IV fluids. So we can't really give them any of that in the dental office, but we would need to stay with the patient while someone contacts EMS, and the EMS always have bags of glucose and an IV, and that's what they need. This person you're going to place supine and monitor their vital signs until EMS gets there, usually about every 5 minutes. Have someone record the numbers so that you can give the time and the numbers to the emergency personnel when they get there. If they really are in need of air, you could give 4 to 6 liters of oxygen per minute. If you're unsure which diabetic emergency that it is, you can always provide glucose because it will not significantly harm a diabetic ketoacidosis patient, but it will significantly help a hypoglycemic patient. So if you're not sure which diabetic emergency it is, always provide some form of glucose. Severe hypoglycemia. This is when you have less than normal sugar in the blood. This used to be known as insulin shock. This is what they called it. The blood glucose level is below 40 to 50 milligrams. 30% of diabetics have severe hypoglycemia, and the causes could be that they missed a meal. They're drinking, increased exercise. So someone that is going to increase their exercise usually has to adjust their insulin dosage. Symptoms of severe hypoglycemia, which is DKA, dizziness, fainting, weakness, headache, intense hunger, cold, clammy skin, profuse perspiration, irritability or aggressive behavior, seizure, and eventually a coma. So if the patient is, if you have someone who is severely hypoglycemic, then, and they're conscious still, you want to put them in an upright position and administer, like we said, 20 grams of sugar. It could be table sugar, honey, candy, orange juice, glucose tablets, or paste. This is what it will be. This is a tablet right here. That comes in a container, and here is glucose. That's like a toothpaste type of thing, and they would need to consume the whole package. Here they would just take some tablets out of there. So you always secure, anytime someone's having any type of a medical emergency, you want to make sure that their airway is secured open, monitor their vital signs and record them. And a positive response should occur within like 10 to 15 minutes after they have consumed the sugar. And for a lot of people, at least in our office, it's almost like instantaneous. It can just be like a matter of, 4 minutes or so, and they start coming back around. So let's say that they fainted or they're unconscious and they have severe hypoglycemia. You're going to have someone contact EMS, and you're also going to maintain their airway. If they are unconscious, they cannot swallow anything. There have been people that have put sugar, like that sugar paste, underneath the person's tongue. But you can't, it's hard to get a whole tube in if they are unconscious. So mainly what they will do when EMS gets there, they may administer 20 milliliters of a 50% for dextrose, or they will administer glucagon, 1 milligram, and they do that intramuscularly, or IM. So if they're unconscious, which you need to remember, unconscious, they will need glucagon. So monitor their vital signs and administer oxygen if they need it. Be 4 to 6 liters per minute.